We're taking this, 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 we're taking with a pinch of salt.
Dear ERA community, ladies and gentlemen, welcome to another episode of the ERA podcast entitled A Pinch of Salt. We're trying to ask simple but often annoying clinically relevant questions to provide you, our dear audience, with simple clinically relevant answers, which is quite possibly the hardest thing to do. We are honored and very happy to have with us today for this challenge Professor Jonathan Barratt. Jonathan leads the renal research group within the College of Life Sciences at University of Leicester. At least that's how Google describes him. However, that rather dry piece of information does not explain a lot and certainly does not give credit where credit is due, because Professor Barratt had the guts, persistence, and mental strength to tackle one of the most frustrating fields in nephrology, IgA nephropathy. And the word itself makes me slightly uneasy. I've always considered lupus to be the disease that I hate the most, but IgA nephropathy is probably the one that I'm most frustrated about for one simple reason. I never know what I'm exactly supposed to do, and I don't feel like explaining that to the patient either. So, I mean, we all know about ACE inhibitors, SGLT2 inhibitors, low protein diet, salt restriction, all very important things, admittedly and for sure. But we also know that sadly that is usually not enough. In fact, there are probably more IgA nephropathy patients on dialysis than lupus nephritis patients. John, how can we solve this conundrum? Welcome to A Pinch of Salt.
Well, it's a great pleasure to join you today, and thank you very much for inviting me. And I share your frustrations. IgA nephropathy really hasn't had the attention it deserves, I don't think, because it is a disease of young people, and invariably it leads to the development of kidney failure.
Yeah.
Not potentially immediately. It may take 20 or 30 years, but because it's a disease of young people, they're ending up on dialysis in their 50s and 60s. And that's a complete disaster, speaking as someone who's in their mid-50s and quite happy not being on dialysis or having a kidney transplant. So for me, I think we've not had to stress ourselves too much because there's never been any treatments around to think about how we manage this disease, but that is changing rapidly. There are lots of new therapies coming. And for me, I think we are nephrologists. Our job is to save nephrons. If we don't save nephrons, we are doctors of failure. We look after people on dialysis and we look after people with kidney transplants. And that's not to say that's not an important job, but we have to accept we have failed. And so when we look at IgA nephropathy and that patient in front of us, we need to think, what are the factors driving nephron loss? And when we understand those, we can then decide how we're going to intervene. And so because most of our patients present late, they automatically have those generic drivers of nephron loss we see in all forms of kidney disease. So they have glomerular hypertension, they have the impact of systemic hypertension, they have the impact of proteinuria in the tubular interstitium. So to address that, we're going to need to do what we've always done: control blood pressure, reduce proteinuria with renin-angiotensin system inhibition, think about SGLT2 inhibitors. We now have endothelin receptor antagonists. We may well have mineralocorticoid receptor antagonists. We may have GLP-1 agonists, aldosterone synthetase inhibitors we may have. So we're going to need to do the general CKD care well, because our young people are presenting usually with a GFR between 50 and 60, which tells me they've lost half their nephrons before I as a nephrologist get my hands on them and can do anything. But at the same time, we need to address the fundamental immunology of the disease, because that's the reason the patient's losing nephrons. And I like to break it down into two major components. What can we do to switch off pathogenic IgA production? And what can we do to control the inflammation that is the result of those immune complexes depositing in the glomeruli? And so if you break it up, you can then start thinking what treatments you might have. And if we draw a parallel with ANCA or lupus, of course we give therapies to stop autoantibody production, don't we? We give B-cell depleters like rituximab, we give MMF, cyclophosphamide. For us, those drugs don't work in IgA because those cells that are producing the pathogenic IgA are living somewhere else. They're not in the bone marrow. They're in the mucosal immune system. So we now have a drug called nephron, which allows us to target that pathogenic IgA production. And we've got lots of trials of new therapies that are going to do something very similar. So I think we're going to have a way of targeting that pathogenic IgA. Then how do we treat glomerular inflammation? Just like we think with ANCA and lupus, we have the option of systemic steroids, but we know the toxicity and tolerability of those is poor. And this is where the complement inhibitors are going to start to come in, I think. We've already seen the impact of avacopan in ANCA-associated vasculitis. We have 6, 7 different complement inhibitors being tested in IgA at the moment. So for me, I think you need to think of that patient. There are 2 drivers for nephron loss. Generic CKD, we know how to handle that. Not peculiar to IgA, we do the good things. And then we target the immunology. We switch off pathogenic IgA. We deal with the inflammation, and we're starting to get new drugs allowing us to do that.
Yeah, we're all very excited about targeted release budesonide for sure, and most of us are probably waiting for it to arrive, but that will happen sooner than later, it seems. But for those of us who have used prednisolone in the past, I think it was quite obvious that at least in some patients it does help. While in others it may not, and while in randomized control trials it might not have been successful. But I always find it a bit odd that the doses that were used in some of these trials are in general, because to give steroids at a high oral dose, which does cause usually a lot of side effects for a disease that is notoriously slow-paced, going over decades, and to give high doses of steroids for 6 months, it sounds not very logical, at least to me. Would it be still prudent to use prednisolone in some cases, but with a different dosing strategy? For example, the Pozzi scheme that was from Italy, where you had more intravenous pulses and then a pretty low oral dose, like 0.4 per body mass every other day. Maybe that's the answer to get the balance between some effectiveness and not much side effects. Have you used this in any way, or?
So I think we need. I think what I come back to, what are we using the steroids for? The steroids are there to target glomerular inflammation. There's no evidence they alter the fundamental immunology or the production of pathogenic IgA. And so the glomerular inflammation in IgA is no different to that we see in ANCA or we see in lupus. There's mesangial proliferation, there's endocapillary hypercellularity, there's crescent formation, there may be fibrinoid necrosis. We're targeting the same disease processes. But we would never think in ANCA or lupus to just give a steroid, would we? We wouldn't give an anti-inflammatory without targeting the fundamentals of the disease. And yet all the studies of steroids in IgA have been of steroid monotherapy. So essentially giving an anti-inflammatory for 6 months and expected to sort the disease out. Well, we know if we give an anti-inflammatory without dealing with the fundamental immunology, what happens when you stop the anti-inflammatory? The disease is still there, the inflammation comes back. And that's what you see in the testing study. You just need to look at the proteinuria graph in either paper to see is the 6 months of steroid, you suppress inflammation, proteinuria goes down, you stop it immediately, the proteinuria comes back because the inflammation's coming back. So for me, I think if we're going to think about using systemic glucocorticoids in IgA nephropathy, we're giving it for the reason, and the reason is as an anti-inflammatory. So why would we want to give more for longer than we would use in lupus or ANCA vasculitis, which is quite frankly a far more intense inflammatory disease? We've got rapid tapers in lupus. We've got Pexivas showed us we can get away with far less steroid as an anti-inflammatory. So that's where it comes back to. You sat in front of that patient. What do you want to do? You want to suppress pathogenic immunoglobulin production. If it was a lupus patient, you'd be putting them on MMF or cyclo. If it was a ANCA, you'd be putting them on cyclo, MMF, or rituximab. If it was a membranous patient to suppress PLA2R, you'd be giving them rituximab. Why do we think in IgA nephropathy giving an anti-inflammatory is going to do anything to the pathogenic immunoglobulin? We need to think about it in that context. So for me, All the steroid regimes in IgA nephropathy are fundamentally flawed. They give massively too high doses of steroid, and a monotherapy of an anti-inflammatory is not going to sort this disease out. We need to give a drug that targets the fundamental immunology, and we're starting to see those drugs appearing. So that's why I think it's really important that people think about what they want to achieve, and they think about IgA in exactly the same context as lupus and ANCA. Target the pathogenic B cells, plasma cells producing the abnormal IgA, target the inflammation when it is present, do it quickly, short and rapidly taper to minimize tolerability, just like in ANCA, just like in lupus.
That sounds exactly right and logical, and I guess it's probably a very similar path that rheumatologists went on when they started treating rheumatoid arthritis, for example, where they probably noticed that the steroids do work, but not as good in the long run. And they went into the field of disease-modifying agents, which is exactly what you're talking about. And if you look at the immunology itself, I mean, the problem with IgA nephropathy is somewhat similar to rheumatoid arthritis in the sense that you have a rheumatoid factor, you have an antibody against an antibody, an IgG in this case against the IgA. So should we be trying? I mean, obviously there are many new drugs on the way, and we'll be waiting for them. But in the meantime, when they're not still for us to use, should we be thinking about other drugs that have been successful in rheumatoid arthritis, for example, like hydroxychloroquine, which was used in an Asian population, but I haven't seen it being used in a different population?
I think that's a really good point. I think we've tried cyclophosphamide, we've tried azathioprine, we've tried MMF. There's some suggestion MMF might work in an Asian population, certainly from China. There's some evidence hydroxychloroquine works in a Chinese population, but we've not done the studies in Caucasians. And I think there's some missed opportunities because hydroxychloroquine is nice and cheap. We know its safety profile, it's regularly used. We're actually just about to start a study in India looking at widely available cheap therapies for the treatment of IgA that, if they work, could be immediately adopted within India. There's no point studying a complement inhibitor in India for immediate use because, quite frankly, they'll be far too expensive and most people will not get access. So I think you're right. We do need to think about what we're going to do in the interim between now and when potential other treatments. So we've got BAFF/APRIL inhibitors. They look really exciting from the phase 2 data. We've got plasma cell depleters that are coming in. So there's going to be treatments available, in my mind, in the next 18 months if the trials become positive. And what do we do in the interim? Well, we could give steroids, but just like the rheumatologists, our patients will fall to pieces if we give them high-dose steroid for long periods of time.
Exactly.
It's completely intolerable. Can we cycle steroids? Well, I'm not sure that's a safe thing to do. We now have Nefecon, which does target and reduce pathogenic IgA production. So that's a possibility, accepting it's not the cheapest drug in the world, and it may not be available everywhere, certainly in Europe. But that is something that has come onto the scene. I can't tell the listeners which of the other agents I would try, but you know the drugs that are being used in other forms of inflammatory GN. And I think we're just going to have to, ideally, in a perfect world, I would put my patients into clinical trials because that's the quickest way we're going to find the data is by getting these trials enrolled and get the data out there as quickly as possible. And all these trials have an open label extension, which means even if you're randomized to placebo, you get the drug before anyone else in the world. So that's a massive incentive for me.
Definitely. And I think probably one problem with that we do have with IgA as well is looking at the markers of success of therapy, when at least, especially when we're trying something that we don't know, that hasn't been as proven and so on. Of course, traditionally it's proteinuria, and there's good data that if you do have a drop of proteinuria, that's good, obviously. It's probably also erythrocyturia, but if you look at the biopsies of patients, and I'm just talking now from some personal experience, you might find that the histology and the amount of proteinuria don't always go the same way. You might have patients with pretty low proteinuria and a catastrophic biopsy, and some with a bigger one. So the correlation definitely is not perfect. And in that vein, when do you actually propose we biopsy these patients? Because obviously we're probably doing it too late. What would your criteria be? Should we go for lower proteinurias when you have erythrocyturia as well, or are we waiting too long?
I think with the new therapies, we certainly need to intervene as soon as possible. And so for me, I think having a biopsy in a patient with proteinuria of around a half a gram and with or without blood in the urine is what I would be wanting to do. I completely agree. Proteinuria can be a marker of inflammation, but it can also be a marker of chronicity. And we can't tell that by just looking at the proteinuria. But equally, hematuria can be a marker of chronic damage to the glomerular basement membrane, as you see in Alports. Doesn't have to signify inflammation. So the kidney biopsy is the way to go. And I think the new paradigm will hopefully be we perform a kidney biopsy and then we institute both the general CKD care, but also the immune-mediated care simultaneously. We don't wait. We get on top of the generic CKD drivers for nephron loss, and at the same time, we get on top of those immune-mediated drivers of nephron loss, because we're dealing with 30-year-olds who've already lost 50% of their nephrons and quite frankly haven't got the time to wait while we do one thing and then wait for another. We would never think about treating any other inflammatory glomerular disease in this kind of stepwise approach that we have done with IgA. And I think that's going to be a massive paradigm shift in terms of how we approach this disease. But the data from the registries suggests that actually what we need to achieve in terms of lifetime rate of loss of kidney function for most of our patients is less than 1 ml per minute per year for the rest of their life if they are going to avoid kidney failure in their lifetime. And that is a pretty tall order, to be honest, almost a physiological aging.
That's almost a physiological. Yeah.
Absolutely. So we haven't got time to wait. You know, it may take 20, 25 years, but these are young people who are still going to be young when they develop kidney failure. And they're not going to thank you for taking their time when they were in their 30s, when they could have had, when they had nephrons to save.
Yeah. So if I understood you correctly, you're expecting these new approaches, anti-complement therapy, April, to be actually available in 18 months. Did I understand it correctly? That sounds really fast.
Yeah, so iptacopan, which is the factor B alternative pathway inhibitor, is already dated with the FDA. So that's theoretically going to get approved in the United States this year if it's successful.
Okay.
The BAFF/APRIL inhibitors, I imagine, will be presenting proteinuria data towards the end of this year, beginning of next, which means that data will be going to the FDA. Now, of course, there is a time lag between being approved in the US and being approved by the EMA. So there will be that delay we need to factor in. But I think realistically in the United States, within the next 12 to 18 months, they will have a complement inhibitor and probably 1 or 2 BAFF/APRIL inhibitors approved for the treatment of IgA nephropathy. And that will soon follow within Europe. So this is a brave new world. Most nephrologists haven't prescribed a complement inhibitor before, and none have prescribed a BAFF and APRIL inhibitor. We use Benlysta, don't we, for lupus? So we're already getting some experience of BAFF inhibition, but these drugs are going to be coming. And the challenge, of course, is going to be they're not going to be cheap. And we're going to need to think how we use them and how we might use them in combination. But that's the really exciting thing about working in glomerular disease at the moment. For the first time in my career, we're going to have multiple therapies we can offer our patients. And that is really exciting, both for patients, but also for us.
That's amazing, John. It almost makes my eyes misty, I have to say, and I'm not really exaggerating, because this was really used to frustrate me a lot. And I can't wait for the time when I tell some younger residents, there used to be a time where we didn't have any medications for IgA. And they will say, no, you're kidding.
It's like we used to tuck the patient up in bed with an ACE inhibitor and say, we'll see you when you need dialysis. That was where we were. And that's where I've been for most of my career. And it's just changing virtually every month at the moment.
Wonderful. Okay, so we went through all the difficult IgA nephropathy related stuff. We just have 2 more questions in the end. One of them is a general one, but still important. So you've been in nephrology for a while. You've had a lot of experience. You've seen a lot of things. What would be the one piece of advice that you would give to a younger up and coming nephrologist, which you think maybe you would be happy if you heard it when you were younger, or something that really needs to be said?
I think one of the things is to know that the older nephrologists don't bite, which means when you go to meetings, when you go and have an opportunity, come and say hello to the older nephrologists, perhaps the nephrologists who've written that paper you really liked, or the textbook chapter that you really liked, because most of my career has progressed because of people I've met and because of relationships that I have developed globally. And I think, COVID is a real challenge. Lots of things are done remotely now, but you cannot beat being in the same room with other people, meeting them, chatting, ideally going off and having a drink at the bar with them. And people approach me. It is a real joy to talk to the next generation of nephrologists. So you should really think, if you're really interested in an area, go and meet the guys, go and say hello at ERA in Stockholm. Go and say hello at the World Congress or the ASN. Tell people you're interested. Start thinking about how you can potentially develop collaborations, how you can chat. Even it may not be that you don't want to do research in your own right. You just want to be kept up to date, and that's perfectly fine. And we're more than happy to be involved in doing that kind of thing as well. The key thing is, the funniest thing is I'm always at a meeting and whatever environment, and I say any questions and there's nothing. And then I get off the podium and I'm desperate for the loo. And there's about 20 people waiting to talk to me that wouldn't ask me a question in the front of anyone else, which is great. But
Exactly.
so please, the advice is young nephrologists, go out, meet people, talk to people, develop those collaborations and relationships.
That's such great advice. I also think that generally people look favorably on other colleagues who are excited about doing something and interested. I think that's always seen as a good trait, and we'll take you up on that. Maybe the loo will seem further away.
Well, anyone who's listening that's coming to Stockholm, if you see me walking around, come and say hello. I promise I won't bite, and I promise I'll have a chat with you.
That's great. Thank you. Because this is exactly when we were thinking about doing these podcasts, this was exactly what we thought about. Let's ask the questions that you don't dare to ask in front of an audience because you're afraid of you might look stupid or something. So
I will just say that there isn't. I will guarantee that if you've thought of something, someone else in the room will also be thinking it, and it will have been asked before. So there are no stupid questions. I promise you, there are no stupid questions. If you need to ask a question, it's because I haven't explained it properly, not the other way around. So don't be afraid to ask questions.
Perfect. Thank you very much. And now the last question, which is like a standard getting to know you question, which is if you were stranded on a desert island, which book, 2 songs, and luxury item would you take with you? We ask everybody that.
Okay, so yep, okay. So a luxury item would be an iPod to listen to music, because I love music. And in terms of 2 songs, I would take anything from the Dixie Chicks, or the Chicks as they like. I like country and blues music, and anything from Muddy Waters. So those would be my 2 songs. And in terms of a book, I think it would have to be The Lord of the Rings, because that's a book I've read many times, but I absolutely love it.
Oh, you got me there. I'm a huge Lord of the Rings fan as well. And the music choice is great. I mean, it's amazing what people choose in these podcasts. You always, when you look at somebody at the podium with the veneer of the academia, you don't really imagine what they listen to, and you're always pleasantly surprised by the choices.
And that's a really good point. You see people stood up on the podium, but they were a medical student once. They were a nephrology trainee once. They went out and partied once. All of those things people forget. And it's terrible because people look at me and I don't feel that old, actually. I think I did those things not that long ago, but it's amazing.
You don't look that old, John. Don't worry. I can imagine you doing stuff.
So I'll tell you this, we're going to Nashville for our family holiday this year, and we've already got our tickets for some concerts there to listen to some country
Oh,
music. So
good.
yeah.
Oh, good. That's perfect. I listened to a lot of country music when I was a kid because my dad was a huge fan. So it was a lot of Willie Nelson and maybe even Hank Williams. Um, so thank you very much. We've come to the end. It was a really nice experience. We're very grateful, and I guess we'll see you in Stockholm, I guess.
Yeah, looking forward to it. And please, it was a genuine request. If you want to come and say hello, it'd be great to meet whoever's interested in talking about glomerular disease and IgA.
Thank you. Thank you very much. Bye bye, everybody.
Bye bye.